Hi guys, welcome back to new next level ophthalmology. Today we'll be dealing with the non-specific orbital inflammation and Tolosa-Hunt syndrome and thyroid eye disease, which form the non-infectious types of orbital inflammation. In the previous class, we have finished infectious causes of orbital inflammation. So let's begin with orbital pseudotumor, also known as non-specific idiopathic orbital inflammatory disorders, which is the new terminology. Earlier examiners might still prefer to use the term pseudotumor, so you have to know both of these. So, what is it? It is a group of non-neoplastic, non-infectious orbital space-occupying inflammatory lesions that can affect any part of the orbit. Okay, it's usually recurring and self-limiting and associated with lot of pain and inflammation. It's rapidly progressing and responds very well to steroids. So histopathological features include lymphocytic infiltration of the affected tissue, and there is an associated PMNLS response with a fibrovascular tissue reaction. So it's a diagnosis of exclusion. So just by looking at a patient, you cannot label them as pseudotumor. So how do we classify them? It can be diffuse or focal. It can affect just the extraocular muscles when we refer to it as myositis. It can affect orbital apex. It can affect the lacrimal gland or the orbital fat or a combination of any of this. So muscles affection is the most common presentation. A 45-year-old woman presented with protrusion of the right eye associated with pain and redness of 2 weeks duration. Past history revealed one more such episode 6 months back, which was self limited. So, we have two very important clues here. It is a recurrent disease, okay, and it is self limited. There is pain and redness. On examination, there is axial proptosis of 5 mm, with decreased range of extraocular movements. Conjunctival congestion and chemosis is present. Blood investigations revealed increased T3 and T4 and decreased TH. Okay, so there are some blood investigations also here. CT scan of the orbit shows the following image. What is the most probable diagnosis? So we know by now that we cannot totally rely on the case presentation here. So the case is a little confusing. It's giving some features of pseudotumor, some features to confuse us. They have given us the thyroid levels. So let us depend on the CT scan. If you see here, you see the medial rectus is diffusely swollen. So this is very typical of orbital pseudotumor. In thyroid, we get a tendon sparing or belly involving picture on CT scan. Okay, so the right answer here is orbital pseudotumor. The sclerosing variant of orbital pseudotumor is associated with which hemoglobin in the serum? So it is IgG4. So this is a not a logical question. This is a memory based question. So IgG4 associated pseudotumor is a sclerosing variant. It's very rare and usually leads to something known as a frozen orbit. Okay, the extraocular muscles get very restricted, and there is enophthalmos following recurrent inflammation, and the orbit becomes frozen. Tolosa-Hunt syndrome, it is a rare idiopathic granulomatous inflammation of the orbital apex. So there is recurrent orbital pain with ophthalmoplegia but minimal proptosis. Okay, so it is a granulomatous response, whereas pseudotumor is a lympho or lymphoid response. Pupillary involvement is also present in these cases. Again, this is also a diagnosis of exclusion. MRI shows inflammation of the orbital apex and an increase in size of the cavernous sinus. Again, Tolosa-Hunt syndrome also has a prompt response to systemic steroids. Now, let's move on to Graves' ophthalmopathy, thyroid orbitopathy, which is a very important presentation in the orbit. So earlier when we were studying, we used to call it as Graves' ophthalmopathy. Now I see many books have adopted this word, orbitopathy. So it is very clear that it is affection of the whole of the orbit and its contents. Okay, it's just not the eye. Okay, so it is associated with abnormal thyroid antibodies. Very important to understand this, whether or not associated with increased or decreased thyroid hormones. So thyroid hormones have got nothing to do with thyroid orbitopathy. It's an antibody mediated response. It is an autoimmune condition. It is not an endocrine condition. It may be a part of Graves' disease. Okay, so 40% of patients with Graves' disease have thyroid associated orbitopathy. In the sense, eye signs are seen in 40% of patients with Graves' disease. So when I say eye signs, it doesn't mean just the eyelid retraction that can be seen in even in hyperthyroidism. There are other eye signs as well. So let us understand them one by one. So what are the risk factors here? Female gender, smoking, use of radioactive iodine. So these are the environmental and genetic factors that can predispose to thyroid orbitopathy. We have known thyroid orbitopathy by many names like endocrine exophthalmos, malignant exophthalmos, dysthyroid ophthalmopathy, ocular Graves' disease, thyroid eye disease. All mean the same. So it is an autoimmune process. So we know in any disease in medicine, we have a genetic component, we have a environmental trigger. So we have understood the environmental triggers, that is smoking, use of radioactive iodine, and some people are genetically predisposed. So we still don't know the actual etiology of Graves' disease. So one proposed mechanism is molecular mimicry. So we don't still know the antigen which is causing the formation of these antibodies. But whatever this antigen is, it is causing the formation of thyroid receptor antibodies. Okay, so these antibodies recognize follicular cells on the thyroid, causing increased production of thyroid hormones, and also they think that the uh, fibroblasts also have same receptors as thyroid. So this is known as molecular mimicry. So the orbital fibroblasts also express receptors which are attracted by the thyroid antibodies. As a result of which, these antigen antibody reaction causes production of some inflammatory cytokines like TNF alpha, interferon gamma, and interleukin 1 beta. More importantly, there is a crosstalk between the TSH receptor and IGF-1 receptor, that is insulin like growth factor 1 receptor. So some mechanisms can be independent of IGF-1 or can be dependent on IGF-1. Nonetheless, there is production of increased IGF-1, both of which lead to formation of increased hyaluronic acid and increased adipocytes within the orbit. So this hyaluronic acid, as you know, is a hydrophilic compound. It attracts lot of water. Okay, and finally, in presence of these cytokines, there is a immune reaction that is forming within the orbital connective tissue. So there is immunomodulatory proteins that are released. Okay, there is increased connective tissue volume, increased deposition of glycosaminoglycans, and a fibrotic component. So all these lead to the formation of thyroid orbitopathy. So the interleukin involved in thyroid associated orbitopathy is it's interleukin 1. Again, a memory based question. The cell that plays a key role in the pathogenesis of Graves' ophthalmopathy is, we just discussed this, orbital fibroblast. So these are cells that are given to just confuse you. So it is the orbital fibroblasts. Let's move on to the next question. Match the following eye signs of thyroid ophthalmopathy. So you have to make an effort to remember these named signs in thyroid ophthalmopathy. They're extremely important for your entrance exam. So Dalrymple sign, it is the upper lid retraction. Enrod sign is fullness of the lids. Von Graff's sign, the most common one, is the lid lag. This sign is very pathognomonic of thyroid orbitopathy. And then Mobius sign is the convergence insufficiency that is seen in thyroid ophthalmopathy. So A is 4 and B is 3. So the answer is probably option D. Okay. Yes, this is the right option. So we'll enumerate the signs again for you. So Dalrymple sign is staring look due to lid retraction. There is another important feature of thyroid ophthalmopathy that is called the lateral flare. If you see this, the contour of the lid here, usually the normal lid contour will be like this, but here there is a flare of the lateral aspect of the lids, and this is very pathognomonic of the thyroid eye disease. This is due to fibrotic contracture of the LPS complex, and it is not seen in other diseases. Von Graff's sign is lid lag. That is when you ask the patient to pursue an object of interest from up to down, you see that the eyelid lags behind the cornea or the globe. This happens due to again fibrotic contracture of the LPS. Enrod sign is fullness of the lids. Gifford sign is inability to evert the upper lid due to deposition of all these glycosaminoglycans. Stelvak sign is infrequent blinking. Jelinek sign is increased pigmentation of the lids. Geoffroy's sign is poor forehead wrinkling on upgaze. And Mobius sign is inability to converge eyes. All of the following mechanisms are responsible for lid retraction in thyroid associated ophthalmopathy except, so we have to find the wrong answer here. Increased activity of the molar muscle due to sympathetic overactivity. Yes, it is possible because many patients with thyroid associated orbitopathy do have increased thyroid hormones. Fibrosis of the levator palpebrae superioris. Yes. Fibrosis of the inferior rectus. Yes. Overaction of the superior rectus. No. So there is no overaction of the rectus. It is not associated with an increased thyroid hormone or anything. So the right answer here is D. So let's understand why do we get lid retraction in thyroid orbitopathy. So there is fibrotic contracture of the levator palpebrae superioris, which leads to formation of adhesions between the orbital tissue and the levator complex. Also, there is fibrosis of the inferior rectus, which leads to retraction of the lower lid during down gaze. And following this, there is an overaction of the LPS complex. So this causes lid retraction, which worsens on down gaze. Okay. Then there may be an associated high thyroid levels, which I said, which leads to high sympathetic activity, causing activation of the Muller muscle, causing lid retraction. So this is a smaller or a minor mechanism. The most importantly, there is a fibrotic component which is causing the lid retraction. A 50-year-old lady was diagnosed with thyroid associated orbitopathy. She has bilateral proptosis with conjunctival chemosis and congestion and restricted convergence. According to the American Thyroid Association, which class of severity of Graves' disease can she be categorized? So one has to know this American Thyroid Association classification or staging of thyroid orbitopathy. So let us remember it as no specs. Okay. N is no signs or symptoms. O means only signs. Here we usually have lid signs. S is soft tissue involvement. There is formation of chemosis, congestion. Okay. P means proptosis. E is extraocular movements restricted. And C is corneal signs or corneal opacification. And S is loss of sight due to optic neuropathy. So we can consider it as 0, 1, 2, 3, 4, 5, 6. So these are the 6 classes. So here we have, there is restricted convergence along with proptosis. So you choose the higher grade. So don't say just because there's proptosis it's grade 3. There is also restricted convergence which is grade 4. So the right answer here would be C. Okay. So let us revise. No specs classification. Class 0 is no signs and symptoms. Class 1 is only signs. Class 2 is soft tissue involvement. Then there is lacrimation, photophobia. Class 3 is proptosis. Class 4 is involvement of the extraocular muscles. Class 5 is corneal involvement. Class 6 is sight loss due to optic nerve involvement. There is another way in which you can classify TAO, that is UGOGO classification. UGOGO is a European classification. So European group for Graves ophthalmopathy. That's what the UGOGO stands for. So here you can classify it as mild, moderate, and severe. Just remember that severe has optic nerve involvement and corneal exposure. So what is mild? What is moderate? This is all that you have to understand. In mild, you have mild amount of lid retraction and soft tissue involvement and very minimal exophthalmos. There is no diplopia, and the corneal exposure, even if it is there, it is responsive to lubricants. So in moderate TAO, you get more lid retraction, moderate to severe soft tissue involvement, marked exophthalmos, and there is diplopia due to extraocular muscle involvement as well. So in late 1980s or early 1990s, there was a clinical activity score that was designed to follow up these patients with thyroid orbitopathy. Okay, so what we do is we give each point for each of these, one mark for each of these points that is mentioned here, based on the symptoms, the signs, and the changes that is seen over the past 3 months. Okay, so based on this, if clinical activity score is less than 3, then we can take it easy. If it is more than or equal to 4, then you have to be a little aggressive with your management. So basically, it is an autoimmune process which has a bimodal presentation. Okay, so it has a congestive phase in which you get all these signs and the eyes red and inflamed, and then finally it is followed by a fibrotic phase. Okay, in the fibrotic phase you get all the sequel of the disease. So what are the clinical features that you see? In soft tissue involvement, you can get photophobia, grittiness, lacrimation, retrobulbar discomfort, and you can see the intense hyperemia of the conjunctiva, especially at the insertion of muscles. There might be chemosis. Then dry eye can be there secondary to involvement of the lacrimal gland as well. Okay, on lid signs, we discussed all the lid signs. Scleral show is when the lower part of the sclera is also shown due to the inferior lid that is getting retracted. Then there can be proptosis, it can be unilateral or bilateral, axial or eccentric, symmetric or asymmetric. So any type of proptosis, thyroid orbitopathy is the most common cause of unilateral or bilateral or symmetric or asymmetric, axial or eccentric proptosis. Okay, just because a proptosis is unilateral doesn't mean it cannot be thyroid. Okay, next is optic neuropathy. It happens due to compression of the optic nerve by the edematous muscles at the orbital apex, and it is not depending on the amount of proptosis. Okay, mind you, just because a patient does not have proptosis, it doesn't mean that he cannot have optic neuropathy. So we can assess optic neuropathy by various tests shown here. And then most common defects seen are infranasal defects due to the bulky LPS complex. Okay. Then there is restrictive myopathy due to fibrosis of the extraocular muscles. So the fibrosis is usually patchy and asymmetric, and thus it causes diplopia, and you may not find a proper pattern of restricted ocular motility. So how do you treat soft tissue involvement? You can just give them lubricants, head elevation, stop smoking. Okay, you can take conservative measures like this. For lid signs, if it's too much, you can go ahead and do a molarectomy. You can do an inferior rectus recession or a botulinum injection into the LPS. Then for proptosis, in it you start the immunosuppression with the help of steroids or immunomodulatory therapy like cyclosporin or rituximab. Okay, and radiotherapy is indicated when you cannot give steroids. Okay, surgical decompression if none of these work. Then optic neuropathy, it is an emergency, so we have to give intravenous methylprednisolone or we have to decompress the orbit. Restrictive myopathy is a little difficult to treat. Um, so you have to give a surgical correction when there is after you have planned a proper decompression. So pick the false statement about investigation in thyroid associated orbitopathy. TSH receptor antibodies correlate with the severity of Graves' ophthalmopathy. This is a true statement because the grade of ophthalmopathy depends on the number of circulating antibodies. Ultrasonography is useful even in the early stages of the disease. It can pick up the bulky muscles, so it is a helpful test. Thickening of muscle spares the tendons as evidenced on CT scan. Yes. So thyroid spares the tendons. T spares T. Please remember this. This is a very important point for your entrance exam. Always associated with high T3 and T4 wrong. Okay. I told you there are chances when you get hypothyroid states as well or euthyroid. The patient can be euthyroid and still you can get thyroid associated orbitopathy. So the right answer here is D. Match the following treatment options with the clinical features of TAO. So lid retraction. Okay, lid retraction is mediated by sympathetic overaction. So the right answer is for guanethidine is a sympatholytic which is not used right now. I have kept this drug here because of historic interest and some old examiners might still want to test you with this drug. Okay. Next is corneal exposure. You have to do taping of the eyelids. B4. Okay. So we are here now. B4, right? See, severe proptosis, you need orbital decompression, and optic neuropathy, you need systemic steroid. So the right answer here is B. Okay. So how do you manage? So it is based on the clinical activity score. First important point is if the thyroids are high, get it controlled with the help of an endocrinologist. There is an urgent need to stop smoking. Smoking is a very, very important risk factor for progression of thyroid orbitopathy. If this disease is mildly active, you can just give local measures, conservative options. If it is a severe or moderate activity, you need IV steroids, radiations, and immunosuppressants until the disease becomes inactive. And after that, you can plan a decompression surgery, strabismus surgery, eyelid surgery, and blepharoplasty, depending on the sequelae. So, antithyroid drugs to decrease the systemic features of thyrotoxicosis, cessation of smoking to slow down the disease progression, artificial tears to give some relief to the patient, radiation when systemic steroids are contraindicated, and systemic steroids in the inflammatory stage to decrease the proptosis and protect the optic nerve. Tarsorrhaphy in the presence of corneal exposure. Uh, Orbital decompression, it can be 2-wall, 3-wall or 4-wall. 2-wall is antral ethmoidal when we remove a part of the floor of the orbit and posterior part of the medial wall. Okay, and it gives around 5 mm decrease in proptosis. Whereas 3-wall involves the 2-wall mentioned above plus lateral wall decompression, which it decreases the proptosis by around 6 to 10 mm. Then 4-wall decompression is additional lateral half of the roof and large part of the sphenoid at the apex, which decreases the proptosis by around 16 mm. So it should be done. This should follow extraocular muscle surgery for correction of squint. So what is the principle here? Whichever is the taut muscle, you have to recess it. Botulinum injection, it can be given into corrugated supercilii to improve thyroid phases and into the particular muscle to bring down the overaction. Once the fibrosis has set in, this may not be very helpful. Cosmetic surgeries include levator and molar muscle recession in the presence of persistent lid retraction. You can even implant scleral graft, blepharoplasty to remove excess fatty tissue or redundant skin from the eyelids. So there are different treatment options available and you have to tailor them according to the needs of the patient. Let's take a question now. A diabetic patient developed thyroid eye disease. Which of the following drugs should be avoided in this patient? So the answer is pioglitazone. These group of drugs are contraindicated as they are shown to increase the progression of thyroid eye disease. Okay. So one IGF-1 receptor antagonist, sorry, this is a small spelling mistake here. Antagonist has been approved for use in thyroid eye disease. It's still not available in India. It's called teprotumumab. It is available in the West and it's very expensive, but it has proven good results. So this is all about non-infectious orbital inflammation. We'll see you next week for the further classes. Thank you.